Dear colleagues, my name is Peter van der Kerkhof. I'm Chief Medical Officer of the International Psoriasis Council, and I have pleasure in this Take 10 to speak with you on general principles for the topical treatment of psoriasis. These are my conflicts of interest, and I would like to start with discussing topical corticosteroids. Topical corticosteroids are effective already within 3 weeks' time. There is tachyphylaxis, intermittent applications, often not effective enough. Unfortunately, we have very sparse safety data on long-term use for more than 12 weeks. Topical corticosteroids have been formulated in lotions, creams, gels, and foams, which enable us to provide in the individual patient an optimal formulation. Local side effects are atrophy of the skin and dermatitis perioralis. We know there are systemic side effects when larger areas of the skin are treated. Suppression of hypothalamic pituitary adrenal gland axis, iatrogenic Cushing syndrome, growth retardation in infants and children, glaucoma, loss of vision, avascular necrosis of femoral head, severe disseminated cytomegalovirus infections. So topical corticosteroids are not without risks. What about the efficacy? We see that betamethasone dipropionate in combination with calcipotriol results in about 60% of the patients in a PASI 75. And we also see there is no difference between once daily and twice daily application. Betamethasone dipropionate as monotherapy corticosteroids will result in a PASI 75 in about 45% of the patients. And then the vitamin D calcipotriol, there is a difference between once daily and twice daily application, with twice daily application the most effective, 33% of the patients, resulting in a PASI 75. Tacalcitol is another vitamin D compound, has a somewhat lower efficacy. And we see that the vehicle in itself also has an effect. We see that up to 9% of the patients with a vehicle only may result in an improvement in PASI. Somewhat more information on calcipotriol. Contraindications. Well, firstly, in the situation that you estimate that you need more than 100 grams per week, you should not apply calcipotriol. For above 100 grams per week, you are at risk in endangering calcium metabolism. Pregnancy and lactation is a contraindication. Abnormal bone and calcium metabolism, renal insufficiency, allergy to vitamin D3 or its constituents. Adverse events. In the combination with corticosteroids, we see that about 8% of the patients have irritation of the skin. That is far better compared to the calcipotriol Divonex twice daily only as monotherapy, where 13% of the patients have skin irritation. And with betamethasone dipropionate, 4.7% of the patients have skin irritation, but also the vehicle in itself also may cause irritation of the skin. When the efficacy of a systemic is not sufficient, we may combine with a topical therapy. Topical corticosteroids plus etanercept improved efficacy without any increase in safety concerns have been recorded. The calcipotriol betamethasone plus adalimumab, high efficacy, especially in the first 4 weeks. Topical calcipotriol plus methotrexate, topical agents with cyclosporin, and topical calcipotriol plus acitretin have been shown to be beneficial, really to contribute. In a way of personalized care, it is important when we see a lesion like this, a strongly in hyperkeratotic lesion. In that situation, when we treat the patient with the biologic, we may also combine in this patient with a corticosteroid under a plastic occlusion or a hydrocolloid occlusion, just to help this very thick hyperkeratotic lesion. We also may apply salicylic acid 10% in an ointment or propylene glycol 50% in water under plastic occlusion. Then I switch to a very old treatment, coal tar, in particular for itchy psoriasis, but still in combination with phototherapy in the Kuckerman regime is in current use in many centers. The PASI 75 is reached in 45 to 80% of the patients. Skin irritation, sun sensitivity, allergic contact dermatitis, skin discoloration may be side effects. And coal tar has a mutagenic potential. That means we have to be very careful in when patient is pregnant to avoid already in an early stage of pregnancy coal tar treatment. But there is good news in the principle of coal tar. That is, in the principle of coal tar treatment, Tapinarov has been developed. And now I explain you the principle of coal tar treatment, which happens to be the same principle as Tapinarov. But Tapinarov has not these nasty side effects. For that are all other principles. What happens is the following. In the cell, there is the aryl hydrocarbon receptor. This receptor can bind to tar products, but also can bind to Tapinarov. In addition, tar does, as I said, a lot of other things, including mutagenicity and so on, and Tapinarov has not these side effects. But now, only the good side of coal tar treatment. It moves the complex of aryl hydrocarbon receptor and Tapinarov to the DNA, and then this leads to a decreased transcription of relevant inflammatory cytokines for psoriasis and for atopic dermatitis. It leads indeed to an increased antioxidant response, which inhibits inflammation, and it improves the skin barrier. And therefore, Tapinarov is both in psoriasis and atopic dermatitis very important treatment. And you should go to the Take 10 video by Linda Stein-Gold, who gives further explanations on this great treatment, also on the efficacy. What we see is about 40% of the patients reaching the PASI 75 and an excellent, outstanding safety profile. There is tazarotane. Tazarotane is a retinoid which selectively binds to the RAR beta and RAR gamma. It affects the epidermis. It's available in a cream and a gel. There is a maximum area that you should not treat more than the maximum area, but irritation of the skin is a very frequent problem, and therefore it's advised to do this treatment in combination with a corticosteroid. Here we have a difficult location, flexural psoriasis and facial psoriasis. And in this patient with true facial psoriasis, you see that within 2 weeks' time, you can get a clearing of the facial skin with calcineurin inhibitors, Protopic and Elidel. Protopic and Elidel have no effect on skin outside the flexures and outside the face, but in flexural and facial skin, the barrier function is somewhat decreased, and that means that penetration of the fairly large molecules of calcineurin inhibitors can do their job. Topical therapy of psoriasis. There are innovations. There are new formulations of calcipotriol beta-metazone by Leo Pharma and Almiral. There is Tapinarov cream by Dermavant. There is roflumilast, which is a phosphodiesterase E4 inhibitor, and brebocetinib by Pfizer, which is a topical TYK2 JAK1 inhibitor. Please go to the Take 10 library and have a look at the general topical therapy Take 10 and the innovative treatment Take 10 by Charles Linde and the Take 10 by Linda Steingold. In our practice, it's important that we personalize topical therapy. We have to ask the question about previous responses to treatments. What's the localization of the lesions? And what are the patient preferences? And then the phenotype. On the left side, a lesion which easily can be treated with a topical. On the right side, we see unstable psoriasis. And in unstable psoriasis, new lesions will appear on normal looking skin after you treat with a topical. Unstable psoriasis should be treated with systemic therapies. Thank you so much for your attention.